Hi, and welcome to ICU Questions for Cooper. This education is being prepared for all of the MICU and CV ICU nurses. Hopefully, we cover everything that you guys have been hoping to learn about OB and how we care for our patients. So, to start off, my name's Andrea, and I'm a nurse on the labor and delivery unit.
And I'm Dr. Cooper, and more than anything, I hope you find this helpful, but never hesitate to reach out to any one of us for any questions you have about any patient, especially an obstetric patient, because you guys are helping us when these patients are critically ill. I know you want to feel more comfortable managing two patients, but sometimes that's hard to do when you're only seeing them on occasion. So hopefully some of this will help, but more than anything, to know to reach out to us for anything that you have. So this PowerPoint was actually put together a few years ago when we had some questions, I guess, from ICU nurses specifically, and literally the PowerPoint just went on to address some very good questions that they had for us, and so hopefully we'll cover some of that. The first one was what are the most common postpartum issues MICU nurse should monitor for? Um, and there you go. Hemorrhage is one of the probably biggest risks that can happen to a postpartum patient, as well as the hypertension, preeclampsia, eclampsia sort of spectrum. Heart failure, we of course worry about, especially immediately postpartum, based on the pathophysiology of what's happening here. These patients can get very sick very quickly as their system floods a whole bunch of blood back into their vascular system and what the heart can tolerate. Sepsis can happen very quickly, especially endometritis that can blossom into multiple organ failure. And then, of course, just post-op complications and PEs that can occur based on the fact that the patient either had a C-section or even more than that, if she underwent a cesarean hysterectomy or a hysterectomy after a vaginal delivery due to sometimes the first one mentioned, which is the postpartum hemorrhage. Um, and so any one of these things I would think would be something that you could encounter. And we'll hit on some of these during the presentation. So next slide. What are the more what are some reasons an antepartum patient would be admitted to the ICU? So she's still pregnant. You're managing both mom and baby. Sepsis, usually from pyelonephritis, that's become a sepsis issue. Every now and then we'll have something else like a seriously ill COVID or flu, but usually pyelo is what lands them over there. Heart failure, pulmonary hypertension, we've seen too much of. Those patients shouldn't even be pregnant, unfortunately, but they can get fairly sick. And based on how the heart changes during pregnancy and the cardiovascular system itself, as well as the vascular system and your blood volume, many times we're seeing peaks of heart failure and pulmonary hypertension right around 28, 30 weeks. And so she's still pregnant. We're trying to maintain this pregnancy for baby's sake, but may not be able to much longer. Certainly trauma. I think they've had a few recently. Excuse me. And these can go lots of different ways, unfortunately. Motor vehicle accidents being the most significant. Usually, if we're going to see a significant requiring delivery trauma, these accidents are involve multiple injuries to mom. I believe the last one was like a 30-weeker. She had multiple broken bones. She ended up going back to the operating room, I think the day after she had a C-section, to fix most of her, like her femur and maybe even a radius or ulna or something like that.
Yeah.
But a lot of these will go down fairly quickly if they aren't already down by the time they get to us. And that has to do with the plasticity or lack of it related to the placenta and something that's called an abruption that can be occurring Certainly, gunshot wounds, knife wounds, things like that can also cause significant trauma that require surgery. But usually, what we're dealing with in those kind of scenarios is, I mean, trauma is always first: ABC, airway, breathing, circulation. And if the obstetrician is there, which many times we are in the ER when they've called us, or at least we're getting there as fast as we can, we're assessing baby status while rest of mom status, but if mom status is no good, baby's no good, period. So resuscitating mom is always first. And there are things that we do to consider that baby could be causing some of that, but if baby's going down, we got to do something about it fairly emergently. And then sickle cell crisis, especially chest syndrome. We manage a lot of sickle cell patients, just very typically on our antepartum service, with the help of HEMOC and some other services, but certainly with chest syndrome. And if they are in need of ventilatory support, then we are definitely calling on our ICU compadres. Okay, so next slide, we talk a little bit about heart and lung issues that happen in pregnancy. Remember, your heart's churning out about 8 liters a minute when you're at full term. A little less than that if you're earlier, but full term's what we worry about. If they've even made it there, depending upon their cardiac status. The amount of blood that's pumped out of the heart is higher, their stroke volume goes up. That's what initially increases at first. So stroke volume goes up at first in pregnancy. You've got some other hemodynamic changes like your plasma and red blood cell. Plasma volume's going up, I think, by 50%, and your red cell goes up as well. So even your lab work can look a little bit different, and I have a slide that hits on that. Your heart rate increases naturally 15 to 20 beats a minute. That's again at full term, so a little bit of baseline tachycardia. We really 110s, we're not or barely budging an eyeball, but 120, 130, that's not normal. Something else is going on. But her normal resting heart rate easily is 100 to 110. There's decreased systemic vascular resistance based on progesterone levels that are elevated in pregnancy. So as a result of that, we're going to see more hypotension, especially early in pregnancy. So her blood pressures early on first trimester should be lower. So if she's spiking some severe range pressures and she's only 10 weeks pregnant, this patient has a very significant blood pressure issue that we're going to see more of if she maintains that pregnancy. You go back to sort of pre-pregnancy blood pressures right around 18 to 20 weeks. And certainly we can see preeclampsia that early, but it's pretty rare. More likely going to be in that third trimester or postpartum. Okay, so next slide, talk about the lungs a little bit. You're consuming not twice as much oxygen, but a lot more oxygen because mom and baby both need it. You're also making more CO2 and you got to get that out of the system. So respiratory alkalosis, and I mean, this is like a perfect system that actually maintains that. The bicarb is lower, but your your PaO2 is up. So your pH looks a little bit skewed with it slightly increased. So your blood gases are a little bit off if mom's still pregnant, but that's actually normal. Again, just because of what the baby needs, but also what it produces. And so mom's got to dump all that CO2 that baby's making too. Her respiratory rate should be normal. When it's not normal, there's potentially something pathological going on. We see an increase in like minute ventilation and things like that, and a decrease in her functional residual capacity. They all feel short of breath, but they shouldn't be short of breath resting. That's usually, again, a sign of a pulmonary issue or a cardiac issue, and their respiratory rate should be normal. If her rate is up, again, something else is going on. Okay, next. So what are we going to do with this? ABCs, airway, breathing, and circulation. Your estrogen levels cause edema to that airway. And so, and your pregnant female, she's going to she's not going to have as much residual. So she desaturates a lot faster. So you've got to pre-oxygenate these patients, but they also crash faster. They look fine, look fine, look fine, and then they're down. Um, Sometimes the baby can show us that mom's on its way down and mom hasn't gone down yet because the system between the placenta and baby is a closed system. It does not fluctuate despite whatever's going on to mom, which is also evidence that, again, if there's decreased blood flow to that uterus, I'm potentially going to see it in the baby first, whereas mom's system can sort of function like that. Anyway, back to her airway. So you want to grab the smaller endotracheal tube. You want your best individual tubing this patient. You don't want multiple attempts. The edema in the airway, and certainly some of our bigger patients can be more difficult, but it'll start chewing up that tissue too, and it'll start bleeding. So it can be really difficult to get these patients intubated, and you want that airway secured. So the best one who's standing there is the one who should do it, which means not me. Um, Again, breathing, if she needs a chest tube, consider placing it 1 to 2 intercostal spaces above where you'd normally place it, because her ribs have spread out and her diaphragm has gone up. And that's from the point that she became pregnant, that her body started to register it, those things change. Even though you don't have to have a uterus pushing up on things in order to cause that shortness of breath, that physiologically has already happened. So move that chest tube up a little bit higher. You want to keep your PEEP as low as possible and keep in mind your ABG changes. You know, again, she looks a little bit, her pH is a little bit increased and things like that, and that's normal. Circulation or your IV access, obviously, this is very important. Lots of patients need to be transfused. You want those accesses above her diaphragm if you can get it. Think about pouring it straight into her heart. That the heart, even if it doesn't work well, is still the best organ to distribute it everywhere else. When you've got lines down in her femorals and things like that, there's a huge, massive obstruction in that giant uterus that's occluding those areas. And so not the best place for your lines. Put them up above her diaphragm if you can get them there. You want to maintain her blood pressure is usually systolics above 100, but we do watch them go lower than that in an otherwise normal pregnant patient and even postpartum, and that can be very normal. But the thing to remember is, do I need to displace her uterus? If she's not pregnant anymore, I'm not as worried about it, but that giant uterus that's occluding things, if she's hypotensive and maybe even a little bit tachycardic, if I just do some lateral displacement of your uterus, because there's something called hypotensive or hypotension syndrome, that when they lay down, if I just displace the uterus manually, just rotate it, then it gets better and it resolves. And then always consider these patients need DVT prophylaxis. Just being pregnant actually puts them in increased risk. Do consider if we're about to deliver her, we don't necessarily want her completely anticoagulated, so we use a lot of heparin sometimes when we're uncertain about that timing, but just something to keep in the back of your mind. All right, next one. So the supine hypotension, this is actually a pretty cool thing when you see it. Usually the only places I've really ever seen it is in the ER. These patients come in on backboards because of major trauma and their neck needs to be cleared, and this is real. You can't rotate that patient. You can't get her, you know, a little bag of fluid underneath her hip because her back may be broken. Somebody can manually just rotate the uterus over, and these images show they literally just kind of pull the uterus over. And if we're scanning the kid or something, we'll be able to see the kid. But if she's above 20 weeks, I would consider doing this. And you can resolve, and blood pressures look better all of a sudden, all kinds of things. Um, the and you're not going to hurt her. You're not going to hurt the baby when you do this. In 20 weeks, how do you know if she's beyond that or not? If the uterus is at her belly button, she is 20 weeks or better. She could have monster-sized fibroids or something like that, and that's very distorting and you can't tell, but that's more rare. For a pregnant woman, I think the biggest challenge we sometimes have is with some of our more obese patients where we can't tell where their uterus is. We can't tell a whole lot based on just manual exam, but that uterus should feel like a big mass sitting in her abdomen. And again, just some displacement laterally. And you can help this resolve in mom. If she's been in a major trauma, car wreck, anything like that, we have a minimum of 4 hours of observation of continuous monitoring, and we'll talk about monitoring in a minute. But that's something, that doesn't mean she has to sit in the ER the whole time. If she's cleared, then she usually comes over to us. If she's not cleared, though, going to the ICU, going to the OR, then again, we have to watch because unfortunately, that kind of trauma not only can result in an abruption, but certainly preterm labor is one of the big ones we worry about. Okay. So postpartum hemorrhage, there are a couple of emergencies that we teach all interns about and then kind of reiterate over and over and over again to get it to soak into their head. This is one you want to recognize immediately. You don't have to have 1,000 cc's of blood loss, but if you do, she's had a hemorrhage. Sometimes it can be less, unfortunately, if your patient is coming in already anemic or the bleeding is retroperitoneal or somewhere else where it's occluded and we can't see it. They can get into a lot of trouble real fast because, again, this patient's been building blood volume her entire pregnancy. And so she is equipped to lose a lot of this blood and handle it. The problem is once she gets to that peak or that break point where she can't handle it anymore, she goes down fast. And so even though there's some safety sort of mechanisms built into the system, if they're beyond those mechanisms, by the time their blood pressure is dropping, they've already lost way too much. You have got to call for the MTP. Do not wait for your shift in vitals. It should scare you, to be honest. There's a couple of things responsible for it postpartum. One of the biggest ones is tone. Atony of the uterus, it won't clamp down after that baby's been delivered, or it won't maintain that tone. And again, this is an emergency that's usually happened after you've just had this beautiful baby boy and everybody's super happy and how fun is this and it's exciting and she's been working to get here and then she's literally crapping out right in front of you. Maintaining that tone, the first thing we teach is put your hands in there. Something called a bimanual massage, where we're massaging from the anterior uterine or abdominal wall and then vaginally as well, massaging, trying to remove any tissue that may still be present, because that tissue and abnormal placentation can certainly just keep going and the tone won't get any better. We're usually calling for medications at this point. Knowing what to use and when to use it and what order should be up to the physician that's there doing things, but at the same time, we're calling and usually our nurses grab all of these things at once. We have a hemorrhage tool that we utilize on our labor unit that has all these medications in one place. But we're usually activating multiple personnel as well, getting help in that room because, again, you got to get IVs going if you don't already have them. You may have to call for MTP and getting people to get in those places, go get that blood, that kind of thing. So bimanual massage, open up your Pitocin, start flooding it in. Many times we'll add Pitocin to the pre-mixed bags that we already have. You can get up to 60, 80 units in a bag of 500 cc's of saline without any issue. Beyond that, it's a little unclear as far as how much pit, but if she's not responding to that, she ain't going to respond to more. Hemabate or Carboprost, I believe it's called, TXA, Cytotec, and Methergin. These are also, again, all common medicines we're calling for. There's a couple of contraindications to some of these. Hemabate, bad asthmatics, we don't want to give these to. However, if I'd rather have anesthesia, intubator, and ventilator if I need to get a uterus to clamp down. And I can give that one IM. TXA is not to get that uterine tone, but actually if we can give it within 3 minutes of delivery of a hemorrhage, then it's considered life-saving. Again, it works in the different coagulation pathway, and I'm sure you guys are familiar with TXA, but we'll give that as well. While we're doing these other things, Cytotec, we place rectally, usually about 800 micrograms up to 1,000 micrograms we're placing rectally while we're still massaging and running these other medications in, because it's going to take a little time for these things to respond, as well as Methergin. Now, if she's hypertensive, please don't give Methergin. You can cause hypertensive crisis and a stroke and some other much more complicated things. So that's a kind of a big no-no there. We use Jada around here very commonly, Bakri balloons. These are, well, one is a suction device we can actually place inside the uterus that will clamp down and help us clamp down that uterus. So, and it just hooks up to wall suction. And again, should be up to the physician that's running that hemorrhage. But if you're there by yourself, remember, bimanual massage until help shows up. Our MTP is a 1-to-1-to-1, which is blood products to FFP to platelets. We do not wait on lab work. Any kind of shift in her vitals, you're already a little bit behind the 8 ball with this patient. If you can hear blood splashing on the ground, you've got a problem. But 2 large bore IVs, again, up above her diaphragm if at all possible. You want to send your labs, send for DIC. And well, I think I have a slide that kind of talks about a few of those, but fibrinogen that's normal is not normal in a pregnant patient. A fibrinogen of 200 is low. It should be 300, 400 easy. And so you glance at the lab and it looks fine, it's not fine. She's in a little bit more trouble. Maintaining her temperature, so we put warmers on them. When they get cold, they don't clot. Maintaining blood pressures, we'll watch their urine output like hawks. Sometimes that's the one vital sign that can shift the most on us, and so being sure they're peeing. And of course, then we got to usually watch for transfusion reaction, lung injury, citrate toxicity, and many times, to be honest, that's when they're going to the ICU because we've been filling them full of this stuff that we aren't as comfortable managing, but we might have got them to this point, but now we need your help getting their acid-base deficits fixed. And of course, all that volume that we just re-gave them is what they need, but at the same time, one problem doesn't necessarily fix the other. Okay, next one. So what are some early signs or symptoms of postpartum hemorrhage the MIC nurse should look for, and how should we expect for it to be treated? Andrea, I mean, you guys call us, so what do you think?
Yeah, definitely. Vaginal bleeding, it should be somewhere around the moderate size, and it really is size. In your flow sheets, you have all of these flow sheets too. You have your OB, PCS body systems. It'll tell you exactly how much would be considered moderate versus large, but a lot of times they're scant. I'm aiming for scant. So if you're having more than that, you need to check the tone. I mean, you're always checking the tone. You're checking the tone every 15 minutes when you go in to look at the bleeding. The fundus should be firm and midline and about 1 to 2 below at this point of the umbilici. We can help you to chart these things. Don't think the first time that recovery is charted that it'll be your responsibility. The nurses are always happy to show you how we do our job. Unstable vital signs. This is going to be a difference from their norm, right? If they were in a trauma, how do you know their norm? You don't really, so you have to keep it between those normal ranges. Anything 90 over 60 or below is definitely going to be hypertension, even in a postpartum patient. Tachycardia, more like 120 is whenever we're worried. No urine output, well, 30 milliliters or less would be something that we would be concerned about. The bladder has to drain. So a Foley is necessary for any patients that are on your floor, at least directly postpartum. If their bladder's full, their uterus is boggy, and then they'll bleed. Just like a cut that you and I have, if you don't apply pressure, it's going to bleed. But
Well, in the uterine tone, we don't go into this job to hurt people, but you physically have to massage this uterus, and their epidural is probably not working anymore. Odds are it's not. It's been turned off, or they're post-op, so they had a C-section, and again, no pain. We're managing their pain, but they're not numb. and you
Yes.
have to massage this uterus. It should be up above the umbilicus or slightly below it. When it's
Mhm.
distended beyond that, I'm worried she's got a huge amount of blood inside that uterus, and they can hide 500 to a liter inside their uterus when there's no tone. And then all of that comes flooding out like a fire hose. And so massaging it fairly rigorously. I mean, I know, again, you aren't there to hurt someone, but she will get hurt if we don't maintain that tone. And usually it stays once it's there, but there are risk factors for it not staying. Like she's had a bunch of babies. She's on MAG, which again, not unusual. And we're sending them over to the ICU, and they're really sick and they're preeclamptic on top of whatever they're sick with. That mag unfortunately kind of softens that smooth muscle a little bit, and so can make it more difficult to maintain that tone. But I believe they do fundal massage every 15 minutes, at least for the first hour.
For the first 2 hours now. And as Dr. Cooper said, we do weigh the drapes, the laps. We have dry weights and weights in our OB carts in all of your ICUs. So you can just take a look at that, minus your dry from your wet, and then that is your QBL. We do QBL, not EBL, because we need to know exactly how many milliliters of blood that this patient is losing. And then we're still going to check labs anyway. So if they lose that 350, and we're not so worried about them having a hemorrhage and we check their labs in 6 hours, then we may consider it to be a loss.
And it's
Um,
also a good way to communicate that weight over, especially, I mean, we're not physically on the same campus. It used to be really different when I could just run upstairs to check on a patient for
mhm.
anybody who was concerned or worried, or the nurse went to be sure everything looked okay. But I mean, we take pictures. I have nurses send me pictures of blood clots.
Yeah.
We also weigh how much has come out and estimate based on that weight. Okay, she's just lost another 500. This is the third time. Are you coming yet? So, we trying to be as objective as possible with what's going on, but also getting the help you need when you need it. Okay, what's next?
Sorry, I'm working on it.
That's
Zoom's
okay.
telling me I'm running out of time. They say I got
Oh,
10 more minutes. I didn't know I had a time limit. There we go.
okay.
Mhm.
So preeclampsia, what to look for. This is the pathophysiology, but hypertension and proteinuria after 20 weeks. You don't have to have proteinuria. The etiology actually happens when you're actually making the placenta, which is, first trimester. The um, endothelial cells, and they get activated, but basically your trophoblasts can invade the spiral arteries correctly. But let's move on if we're short on time.
Okay,
It makes no difference how it happens. What you want to do with it next is the problem.
fantastic.
So you may or may not have symptoms, but think ischemia or necrosis to your end organs, especially like the liver, or edema to the lungs. Your patient is actually volume depleted because everything is third spacing. It's going to the wrong areas. She may look puffy and full of fluid. It's not in the vessels. And so it can be more difficult to manage these patients because everything you put inside of them won't stay there. Their albumin is normally low. That's totally normal in a pregnant patient, but they also, their vessels, it's like they start leaking a little bit when they've got severe preeclampsia.
It's
Keep
true.
going. So in mom, some of the things we can see, seizure activity, of course, is eclampsia, cerebral edema that can actually lead to blindness. We've seen this a couple of times. It is not fun when you see that. Cerebral hemorrhage, we've got to maintain their blood pressures and keep them out of stroke range. But those severe range pressures, they can hemorrhage into that vascular space so fast. And of course, strokes, liver failure, and bleeds from the liver, hepatic rupture, subcapsular hematoma or hemorrhage. These are really difficult to manage, but the patient is usually in a lot of pain. Um, Certainly, DIC and HELP syndrome is part of this spectrum. Renal failure, so they can become oliguric to anuric, which is always dangerous. They're spilling a ton of protein, usually over 300 milligrams in 24 hours, and we've seen them, 50 15, 16, 18, 20 grams of protein. You don't think these kidneys are ever going to recover, and yet they do. It usually just takes time. And of course, the pulmonary injury is usually related to lung perfusion, or I'm sorry, like pulmonary edema, where she's third spacing that volume and fluid. On the baby side, a lot of times it's resulting in preterm delivery. Sometimes growth restriction or IUFD is even a possibility. That fetal distress, because this is all about blood flow. You start compromising that blood flow to the uterus, and I got a problem with baby. She can certainly abrupt, and that's usually an obstetric emergency when that's occurring and related to that tenuous placental attachment to the uterine wall. As far as hypoxic neurological injury, always in the back of my mind when I'm taking care of any obstetric patient, oligohydramnios is one of those signs we can see in baby, just because, again, the placenta is not being perfused as it should. All right, next slide. So what are you going to do? What are you going to help us with? MAG. She has to be MAG'd. We have to balance mom and baby as far as delivery. It will depend if she's super early, not necessarily, but how sick is she? Is this mild or severe? Usually based on blood pressures or other end organ damage. Is she eclamptic? There's no reversal for eclampsia. You must deliver. And of course, we've got to control their blood pressures, usually, and as well as MAG. Now, it doesn't necessarily mean she needs a C-section. It just, what's the favorability of her cervix? How far along is she? Will the baby tolerate labor? Those all things we're taking into consideration. Medications we use on the labor unit and would encourage you to use in the ICU. IV labetalol, hydralazine, and PO protocol or Procardia. They're all very well written protocols for all of these, as far as where to start, how to increase and go up on these medications if the patient continues to spike severe range pressures. Unfortunately, this disease can onset even after delivery 25% of the time, and that's odd because the treatment is delivery. The treatment is not MAG, the treatment is delivery. If I get her delivered, technically I should get better. However, I've especially with our eclamptic patients or severe range, severe preeclampsia, many times it's about 72 hours before they'll start getting better. But you got to control her blood pressures. You don't want her to have a stroke or a hemorrhage into that anywhere. And usually things like the cerebral blindness and stuff, once the edema starts resolving, that can be better. We're very careful on how to pull that edema, especially with medications like Lasix, because remember, she's just third spacing that fluid. She's actually volume deprived, and so is the baby. So it's a real tight management that we do. Okay, next one, MICU nurse's role if we crash, where to occur on the unit. I would tell you it's going to depend on if I've got a labor unit there nurse there to assist me, or a baby nurse was present, which they should be because we pretty much were coming over there together. But if they're not, then I would be having you assist there. Otherwise, you're going to be helping with ventilators, lighting, especially if I don't have anesthesia, and getting our equipment. Otherwise, literally any of the OB residents can handle this. It takes them about 60 seconds to get to the baby, but then we have to resuscitate that baby. Just like you resuscitate a mother with, breathing and bagging them and things like that. Sometimes chest compressions, it depends on what's going on, but many times that's all you're doing. Or, getting that equipment where we got to go next.
Fantastic.
Probably,
Yes, helping with that.
understand. I'm almost out of time. Sorry about that. So reasons a patient would be on PIT or MAG after delivery and how long do they normally stay on it? PIT is usually 1 liter bag, 20 to 30 units in that bag. And once completed, we're done, unless she's at significant risk for losing that tone and we're worried about delayed hemorrhage. MAG is usually 24 hours after delivery, especially if she's severe pre-E, to prevent that seizure activity from happening. We don't check MAG levels, but there are some exceptions, especially your renal disease patients that may not be clearing it. Next one, MICU nurse know about uterotonic tocolytic agents. So we already talked about the ones that make the uterus tone, but tocolytics or to relax would be things like breathine. Which dose to give sort of depends on how fast she's contracting. and how much I need to slow it down. It's a sub-Q medication, but I'm not going to give it if she has a known cardiac arrhythmia or heart disease. And I'm going to tell the patient, hey, this is going to make your heart race, but we're going to slow these down a little bit to help baby out. One or two things you would absolutely want ICU staff to know about your patients, what would that be? Number one, we're a team, so involve us with anything you're concerned about. Do not hesitate to contact us if you're uncomfortable. We are always available. There are 4 doctors over here at all times. So now sometimes we're all spread out all over the place, but there's going to be somebody who can get you someone who can help. Once baby's delivered, many times that's actually when we need you more than we did before, because mom's system doesn't always like all those vascular changes when that blood starts pouring back into her system out of the uterus and back into where she is. And so many times those underlying problems like unknown heart disease or even known heart disease, pulmonary disease, this is when they get sick. 24, 48 hours after delivery is when they can crash over here on us, and when I literally can't do anything with them or don't know what to do with them. To help support them so that the heart will start working again. So a lot of times that's where, and maybe you're sort of feel like you might be babysitting a patient who's otherwise fine because baby's delivered and pressure seem controlled. But again, that's when her system sort of rejects us and can get into a little bit more trouble. So that's where we want to be our most careful with these patients.
Oh,
All
and we
right.
made it through. So, just briefly, if you were able to see that information on spinal precautions, that's the only thing that we haven't covered, and we have 1 minute left. Spinal precautions, the patients have to lay flat. And what do you encourage?
So again, it's more of it lifting the uterus and rotating them. So she's got to be flat. That's fine. Can you airplane the bed? Because she'll stay flat if you airplane the bed.
Mhm.
And you know, we our anesthesiologist many times put a liter bag of fluid underneath her right hip before we do C-sections and things like that, but they put it underneath the cushion of the bed. So is
Mhm.
that a reasonable thing? Again, what's reasonable and what's not? And do we manually have to just rotate baby? Does she need to be completely tipped over?